It's great to see everybody here. My name is Naushira Pandya. I'm a professor and chair of the Geriatrics Department at Nova Southeastern University in the Kiran Patel College of Osteopathic Medicine. And I also head a geriatrics workforce grant, which is a federally funded grant to improve and train health professionals and caregivers on the care of the elderly. So let me just give you a little background on and set the stage for what we're going to talk about today. So I have no relevant financial disclosures, just that I'm tired and I need a vacation. That's my disclosure. But I know we could all say that, right? So what I want to set the stage for this panel is we're going to talk about the scope of Alzheimer's disease, which I will address, and the impact on communities. And then we'll talk about advances in Alzheimer's care, some research information on treatment, and what is new in sleep and dementia. We'll bring some research perspectives from our department, and then we'll be able to discuss if time allows, some research updates from the Alzheimer's Association. So I'm sure many of you are familiar with this picture. This is the rising projected number of people over age 65 who will be affected with Alzheimer's disease. And you can see we're halfway through in 2020 or so. We have about almost 6 million people who are affected. But by 2050, we're going to have almost 14 million people with Alzheimer's disease, and about half of them will be over 85 years old. And fortunately, people are living longer, but the problem is that the prevalence of Alzheimer's disease will rise in this population. So this is a real challenge. What do we do? How do we detect it early? And how do we push aggressively for treatment modalities? And what we need to do, obviously, behind all of this is support caregivers. And so if you look at Alzheimer's disease state by state in 2022, where do we stand? Where I've circled is Florida, and we're not doing that well. About 28 to 33% of the population of older adults has Alzheimer's disease. So our state is one of the highest in the country, and you see other states in the West Coast and the Northeast, all the darker purple areas. So we're already where much of the country will be in 10 to 20 years. And so I think we, work that associations, universities, and caregiver organizations are doing is incredibly important for us at this point in time. Now, a lot of people get confused about where Alzheimer's is in the scope of dementia. I hear often my patients say, well, I don't have Alzheimer's disease. I have, my mom has a bit of dementia. Well, dementia is a broad term. It's an umbrella term. So it's a disease. It's a syndrome. It's not one specific disease. And Alzheimer's is one of the diseases that causes dementia. Okay, so it's an umbrella term, dementia, and you can see under that the majority of people have Alzheimer's, and then Lewy body dementia, which is a specific, very rather fast-moving dementia, comes next in 5 to 10%. And then about 10% of people have vascular dementia, which is dementia from strokes, transient ischemic attacks, damage to the brain circulation from hypertension, high cholesterol, diabetes. Okay. And then we have other types of dementia, frontotemporal dementia, and dementia associated with Parkinson's and other complex movement disorders. So dementia is a broad term, and Alzheimer's disease is certainly a form of dementia. The tragic thing, I think, is that it's not diagnosed early enough. It takes 3 to 5 years for an individual to have a definitive diagnosis from the time they begin to show symptoms of memory problems or behavioral problems. And there are multiple reasons. I think there's lack of resources. I think often families compensate and feel, oh, this is my mom getting old, this is normal. Okay, so I see some nodding heads. And so the tragic thing is that the diagnosis is delayed, and there are not that many places that can make a confident diagnosis for you or a family member with dementia. The other problem is that communities of color are almost twice as likely to be affected by Alzheimer's. So Hispanic patients almost twice as likely as African Americans to be affected by Alzheimer's. And that's the big problem, is how do we reduce that prevalence? What is it in these communities that leads to this higher prevalence of Alzheimer's disease? What's the impact on our society? As I mentioned, it is the most common form of dementia, Alzheimer's disease. Currently, it affects 6 to 8% of those over 65 years old. But over 85 years old, about half that population is affected by Alzheimer's disease. And as the numbers of older adults rise, we'll see higher numbers of Alzheimer's. I've talked about vascular dementia. Sometimes vascular dementia occurs at the same time as Alzheimer's disease. It can be a mixed dementia. You know, nobody comes in a simple package, right? I've never met a patient in the older age group who had one diagnosis, because they have multiple problems: hypertension, diabetes, high cholesterol. So vascular dementia can coexist with Alzheimer's disease. And then there's Lewy body dementia, which is rather progressive. You can see hallucinations, early features of Parkinsonian type movement disorders. Frontotemporal dementia is a dementia where you have disinhibition, problems controlling behavior, nutrition, sexuality. And this is a tough diagnosis because there really is no immediate treatment. And then alcoholism, other neurodegenerative conditions can cause Alzheimer's, including Parkinson's disease, can cause dementia, including Parkinson's disease. In the later stages, some patients with Parkinson's will develop dementia, which is distinct from Alzheimer's disease. Okay, but it is a type of dementia causing problems. So the economic impact on this country is huge. These are slightly older statistics. $818 billion is spent annually in medical care, social care, and informal care by caregivers. All right. Medicare and Medicaid covers most of the cost of the care, but not all, and private insurance companies. The remaining cost is borne by caregivers and families, which is worth about $230 billion. And I don't have to tell anybody here, the emotional toll on patients and families is huge. How many of you in this room are caregivers or have been caregivers? Almost all of us, right? And so it is a difficult job, and hopefully I'll be able to tell you some ways, and along with other panelists, of how we can provide resources and make life a little easier for caregivers, because it takes a toll in terms of your health, your own mental health as well. The news is not good in terms of mortality as well. If you look at causes of death from cancer, breast cancer, prostate cancer, even stroke and cardiovascular disease are going down. So we're doing better with those chronic conditions. But if you look at the last bar on the left, the purple bar, percentage change with cause of death from Alzheimer's disease is rising. It's the only chronic condition where the numbers and the causes of death are rising. So, it's a really sobering thought, and it is probably the most important chronic condition in older adults, along with, the other, what I call baggage, all right? So what I want to just show here is older adults, may have Alzheimer's, but they have other problems, right? They've had hypertension for a long time. They may have diabetes, heart failure, chronic kidney disease, which is very common in older adults. And the point of this slide is just to show you that the average costs for Medicare payments for people with these coronary artery disease or diabetes with Alzheimer's is much higher than those without Alzheimer's. So if you have Alzheimer's and medical comorbidities such as diabetes, chronic kidney disease, and heart failure, the cost of care for that person, average cost, is much higher. And we not only want to look at the dollar cost, but also what is the informal cost? What's the emotional cost? What's the cost to family members, caregivers? So just a quick review on risk factors for dementia. Let me look on the positive side. On the left, you see protective factors. So protective factors, possibly ways to protect yourself, could be good blood pressure control, and that's from now. From midlife going forward, good blood pressure control is important in terms of reducing your likelihood of developing dementia of any kind. Okay. And physical activity. Just walking has been shown to reduce the risk of dementia. Okay, just walking every day. All right, cognitive training, so learning new things, and structured programs where they train your mind to open up new areas, new abilities. So that is shown to reduce the incidence of dementia. And there's a lot of work and funding through the NIH to do cognitive training to see if that helps to prevent or delay the onset. And education. So the more education you have, the less likely you are to develop dementia. So that helps, using different parts of the brain, always learning, continuing to learn. The risk factors on the right. We know definitely that age is a risk factor, family history of Alzheimer's disease, having a genetic abnormality, which is one of the ones that's been identified is called the ApoE4 allele. That's a risk factor. Having Down syndrome is a risk factor for Alzheimer's disease. So that's not to say everybody with those conditions will develop Alzheimer's, but there are risks. The possible risk factors, so we're not there's no definitive pronouncement on this. Possible risk factors are head trauma. It can increase the risk of dementia, especially repeated head trauma. And fewer years of formal education. Isolation and loneliness. There is a lot of research being done, especially during this time of COVID, that people who got isolated are developing more cognitive problems. Okay, so isolation is not good. This is something that I think a lot of people are aware of. Sometimes we can address this and other times we can't. But isolation and loneliness are known to increase your risk of dementia. I already talked about hypertension, controlling your cholesterol levels, your blood glucose, and maintaining your weight. Because people who have obesity are also at increased risk of dementia. All right. So a lot of this sounds gloomy, but I think there's a lot we can do in terms of prevention, in terms of activity, blood pressure control, cholesterol control, knowing what your blood sugar is, and keep learning new things. You've probably seen this picture many times, but a lot of research is being done in what parts of this pathology of Alzheimer's can we address to improve it or to reduce the incidence of Alzheimer's dementia. So you get tangles in the neuronal cells made of tau protein, and you get plaques outside the brain cells in the brain tissue, which are made of amyloid. And you see the picture of the MRI, which is quite advanced. It shows a lot of shrinkage of multiple areas of the brain. Now, early on, there are only certain areas of the brain that are affected. So what we want to do, obviously, is to detect this disease early on. Unfortunately, this disease, the changes in the brain can take place even 10 years before the final diagnosis of Alzheimer's. So this is the really hard part, is when are these changes happening? What can we do early on? Do we know who these changes are occurring on? And there is research being done about even screening normal people who is at risk for Alzheimer's. So there's a preclinical stage where there may be brain changes without any symptoms. The individual may not notice anything. And then there could be a stage where there is the beginning of forgetfulness or dealing with complex tasks. And then the second stage, mild cognitive impairment, is memory changes which can be of concern to the individual and family, but they are able to continue their activities of daily living. They're functioning in a normal way. So that's MCI. And then you have the development of dementia, where you have memory problems, cognitive impairment that's severe enough to affect your way of life, to affect driving, to affect management of finances, taking care of yourself, where you need additional help. Unfortunately, a lot of people come to diagnosis in the later stages, and that's the difficult part, because what can you do in that stage? And helping caregivers and helping to improve the quality of life of patients is something we can definitely do even now. Okay, so although intensive work is done, we need to support caregivers from the beginning, as I state in this slide. The natural course of this disease is this yellow line. There's a sort of slow phase and then quite a rapid decline. And it varies. People can live, 9 to 10 years with Alzheimer's disease. So this is the natural cause, okay? And this is, with current treatments, we can delay time to death. We can delay the pace of deterioration, but we're not doing too much, all that much better right now with current treatments. We're delaying things a bit. Ideally, we would like to not reach that stage of dementia, but continue with cognitive impairment and maintain quality of life. So that's why research, early detection, and early treatment are so important. So let's begin with our panel now, and I'm going to ask Dr. Shane Moskowitz to take the stage. And thank you so much.
Good morning. Good morning. Thank you. To introduce myself, I'm Shane Moskowitz. So I'm a neurosurgeon at Broward Health, the neurosciences medical director for the system as well, and the PI, the primary investigator, for a study that we're participating in. And so it is a hyper-focused talk, and I appreciate the ability or interest in learning more about this. So specifically, the protocol that we're looking for is for Alzheimer's disease and its prevention and treatment using ultrasound. To put this in perspective, I thought this was kind of fascinating. So we're now at the 116th anniversary of the description of Alzheimer's disease in its original form. Originally, it wasn't called Alzheimer's disease, but Dr. Alzheimer himself described in this first patient, and her name is Auguste Dieter in Germany. At the time, she was 50 when diagnosed by him. He was a neurologist at the time, and followed her clinical course over 5 years, which was a fairly rapid course and an early onset of Alzheimer's disease to become Alzheimer's disease. And at the end, where she continued to progressively lose her speaking ability, the last thing that she was able to really speak about or say is, "I have lost myself, so to say." And that's all she could say, is repeat that phrase, which is unfortunate and ominous and very creepy all at the same time. Because in essence, that is what everyone here, I guess, has accepted or understood is the reality of what we now call Alzheimer's disease. It's a progressive decline in cognitive function, ultimately resulting in profound memory loss, and changes that are seen on pathology after the brains are able to be seen under a microscope. And so at the 116th anniversary of the description of a disease which we now know is named after him as the Alzheimer's disease, this is, again, more data pointing to the same thing. As we live longer, because healthcare is getting better, people are now living long enough to now have diseases that really weren't really relevant in the past when the mean age was only 65, and we're not talking very long ago where the average life expectancy was 60 to 65. That was in the early 1930s. That's where that number came from. People didn't live long enough to get Alzheimer's disease, so it wasn't something people saw very often. Well, unfortunately, the mean age today in the United States anyway, is about 80, 81. That's the average age. So people are living long enough to accumulate time to now develop diseases that really weren't seen in the past. And so as the average mean age in the United States keeps going up, the population of those that are over 65 essentially nearly doubled, which leads you down the road of having what's estimated, as you saw just moments ago, a number of folks with Alzheimer's disease diagnosed at almost 14 million in 2050, which is not very long from now. Some of the implications are huge, both in terms of health care. Just to point that out from a hospital perspective, that for every 1,000 people with any form of dementia, there's 1,500 plus annual emergency room visits, and of those that show up to the hospital and are admitted for whatever medical reason, and it's not even relevant, if you have dementia, you have a readmission rate of almost 1 in 4. So anyone who comes to the hospital has a 25 to 23% chance of leaving the hospital and coming back within the next month for recurrence, for more problems, is because of care, self-care, and just general systems that make Alzheimer's disease so profound, even in the absence of the medical issue being related to the dementia itself. The cost to the healthcare system is profound. It's estimated, at least today, Medicare, which is the government, HHS, which is sort of most of what healthcare dollars are spent in anyway, spend approximately $30,000 a year per person. All people, $30,000 per person in the United States is being spent to care for those with Alzheimer's disease. And for those that are here, to comment on the workforce slide, I think those that are here, if it makes folks feel they're in good company, because they are. In the state of Florida, just the state of Florida alone, 1.8 billion work hours are spent, unpaid, per year to care for someone with dementia. So for every hour that everyone here spends caring for their loved one with dementia, you are in good company, because there's a lot of time being spent caring for these folks, unpaid. I'm not saying we should do it any differently. My point is that the economic impact is profound from a system perspective. The same slides that everyone knows, amyloid pathology and tau protein deposits result in brain cell death. It's that simple. It typically targets areas on the middle portion of the brain and the inside of the temporal lobe, which affects memory, personality, spatial skills, cognitive function, which is why these are the areas when these areas are affected, those are the areas that are typically going to show the problems with cognition. So Alzheimer's disease as a disease process often comes with memory problems, emotional lability, processing problems. So it all matches anatomically. Treatments these days are, and here's kind of the big umbrella laundry list of things that we do to treat folks who have, from a healthcare perspective. There's medical management, and we really, unfortunately, are focusing on symptom control or support. So medications that we use, like Aricept, Exelon, Razidine, are to hopefully improve memory. Namenda, same thing. We're looking to improve. It doesn't undo anything. Sleep disruption, as you're going to hear about, is incredibly common in the setting of Alzheimer's disease. Medications are geared toward improving sleep quality. As for disease-modifying therapy, and that's really, to an essence, what we're looking to try to accomplish, is how do you alter the course of the disease, not just make things better. And the easiest way to understand that is the same thing as being infected with something. You can get a bacterial infection, you take an antibiotic, you kill the bacteria, you recover from the course of the infection. You alter the course of the disease by treating something. The flip side would be a viral infection. You get a cold. You take whatever medication you want, and it's not going to change your cold. Your cold is exactly the same. You have to ride it all the way through. Your body will clear the virus by itself. What you're treating are the symptoms, the runny nose, the headache, and whatnot. You're not changing the disease process. So what much of the therapies that we're really gearing toward is to support, not actually alter. There is a directional change for hope is to actually modify the disease themselves, and there's really not very much there. The monoclonal antibody, the aducanumab, which came out last year, it's FDA approved. There is some, we'll call it controversy about the mechanism with which it got through the FDA and whether it really works, and that is not the purpose of bringing it up. But my point is, it's not a cure-all. Lecanemab is now to be determined. That's the study that came out last month with phase 3 data that seems to suggest, at least by their press report, that it improves the disease itself, to be determined once the data comes out. And so that's it. As disease-modifying therapy, there really isn't any. And the next avenue that we look to focus on is our environmental and supportive care to address that. And that includes behavioral therapies, cognitive therapies, physical therapies, social therapies. We're really looking to support and improve quality of life. That's the laundry list of what we have today. Doesn't mean we're not trying, but it does mean that we don't have a lot to actually really impact the biological component of the disease. So where is the research going? Well, it's not something that is unrecognized within the healthcare world. We need to do something better, and the number of studies that are out there are extensive, and I imagine, Keith, you're going to talk a little bit more about that too, but here's a quick laundry list of some of the things that are there, later versions of the studies that are out looking to address pharmacologic or interventional options, and that may include semaglutide, which, by the way, his trade name is Ozempic. I have no financial interest, nor in any way, but that's a name that everyone would recognize. There are a variety of medications that are out there that are either geared towards stabilizing the amyloid so it's less toxic, or ways to prevent amyloid from clumping together. It's another medication. Things that may prevent cell death, neuronal cell death with calcium channel blockers. Intrathecal gene therapy. So now we're really talking sci-fi, which is to try to introduce viruses into the spinal fluid that trigger the production of the apolipoprotein E2, which is protective against the E4. Maybe we can get more of the good protein and help change that. Bone marrow stimulation. So that in some sense we're really looking as many ways as possible to attack this disease medically. And then on the bottom half, I left those separately. Are medications and options that are geared as well for not just the actual amyloid disease process, but really more geared toward changing perhaps the symptomatology. So dextromethorphan, pot analogs, other medications, again, not looking to treat the disease, but really looking to treat more some of the symptoms. In this case, agitation. Deep brain stimulation of the fornix, same thing, looking to gear toward changing not the underlying pathology, can't change the disease, but maybe make the symptoms better. Transcranial magnetic stimulation for apathy. So we're looking now not to change the disease, but maybe we can be more effective at changing the symptoms that it comes with. So where are we? What is this introduction really about? And just to give you a window into one of the studies that we're involved with, this is at Broward Health, using focused ultrasound to actually modify the therapy. Focused ultrasound is very much like stereotactic radiation, as an example. So we're all standing here on the stage, right? So if we had one giant spotlight, kind of shining light onto the stage, well, we would get all the light, but so would everybody along the way, right? So instead, in order for the stage to be bright and the audience to be dark, there are, I don't know, 75, 100 lights in the room, and they're all pointed at the stage. So everybody in the audience only gets just a little bit of light, so you can see a little bit, but not a lot. But everybody on the stage is shined on with the maximal amount of light. All of the focused beams of light are focused on the center. that premise is what we're talking about here. By using many different ultrasound probes, all emitting very low amounts of energy, they're all concentrated in a single point. That single point then gets the full dose of that energy source. Now, it could be radiation, and that's how cancer treatments, for example, in the brain are treated, but it could be any source, really. And so in this case, it's ultrasound, where the focus beams all focus on one spot. Now, that's not necessarily a brand new technology. It's already used, it's already approved, it's already part of standard of care for very, very specific movement disorders, like essential tremor or Parkinson's disease, where using high-focused energy sources can literally fry a piece of brain the size of a grain of rice and not affect the rest of the brain. This is very cool. And you can burn, if you can see the bottom right picture, you can see a tiny little hole that's actually burnt into the brain. It's great if that's what you're trying to accomplish. If you're trying to destroy a rice-sized piece of tissue, this is a great technology to be able to do that. But it's destructive, right? That's the premise, and that's the intent, so it works. What we're talking about here is now not destroying brain. We're not trying to damage any tissue. We're trying to alter its function without destroying it. And so it turns out that we can use this ultrasound and dial it down in a way to be able to, rather than destroy tissue, but alter the blood-brain barrier. Now, the blood-brain barrier is basically there to keep bad things out of the head, viruses, chemicals, things like that. By keeping bad things out, the brain is then protected against all the bad things that normally circulate through our system. Medications, drugs, proteins, viruses, it's protective. Problem is that once you've got this awesome security wall, once something is on the wrong side of the security wall, there's no way to get rid of it. You just breach the security wall, you can't get rid of it. And so amyloid, in many ways, the protein that gets deposited that causes the cell death, once it's on the inside, has no way out. Can we use this to help get rid of it? So what we know, and here's a list, and there's a logical flow. It's not something that's been made up. You can use this focused ultrasound to open up that blood-brain barrier. The analogy I give is like a screen door. You can open the screen door, and it doesn't stay open for very long. But if you open the screen door, all the dogs in the kitchen have the ability to run out of the house. Now, if you close the screen door closes behind, you're not going to get rid of all of the dogs, but if keep kicking open the door, eventually all the dogs are going to leave, right? So can we use the same analogy, and pardon me because it's not exactly the same, but conceptually, you can use the ultrasound to disrupt the blood-brain barrier, open the door. We know that there's a therapeutic window where that can happen. So you only open the door eventually closes. We know that it can force apart the tight junctions. That's actually the screen and the mesh of the blood-brain barrier, and that enables molecules to cross both directions. The dogs can get out just like mosquitoes can get in. So it can go both directions, right? But can we use that to harness the idea of opening the screen door to reduce the protein deposits? Because now they can leach out. And the answer is yes, because in certain animal models of Alzheimer's disease, essentially, there are mice models where amyloid is deposited. By using this technology, you can open the door, leach out the amyloid, reduce the amount of protein that's toxic to the brain, and in doing so, clinically, when you'll have to take this with a, with a research mindset, in an animal model, you can improve cognitive function. For mice, it's mostly visual spatial skills, meaning their ability to navigate a maze and stay on bars and things like that, things that mice need to do. By opening up the blood-brain barrier, you can reduce the amyloid and improve cognitive function, or at least preserve cognitive function in animals that are guaranteed to get Alzheimer's disease in a mouse. And so here is the premise of this study. Can we do the same thing in people and get the same kind of benefit? And so we know that you can open up in a very focal way the blood-brain barrier, which means that we can target areas that I mentioned before, target those areas that have deposits of the amyloid protein. It's a technology that's coupled with MRI, using these ultrasounds to very specifically open the blood-brain barrier in areas where the amyloid is being deposited, allowing this to leach out. So this is a study that we're very proud to be part of. So it's us, partnered with the University of Florida, the company of Insightec, and funded by the state of Florida. And the purpose is really to see whether or not we can improve Alzheimer's disease, preserve cognitive function safely by disrupting the blood-brain barrier. And so there are the study objectives. It's both safety and efficacy. We're looking to prove that both you can do this, you can keep opening the screen door safely, and in doing so, over the next 5 years, improve cognitive function. Back to that graph with the yellow lines, can we actually alter the yellow lines so that they're not yellow and eventually nosedive to the ground, but at least level out, which in and of itself has great utility. And again, study objectives, things that we're looking for. And we have a lot of screening to this. It's not something we woke up and said, oh, anybody can do this. We're being very, very specific about what we can do and what confirming that they have Alzheimer's disease and confirming as best we can they don't have other comorbid problems that would make this study not possible. And then in doing so, we would do this, that kick the screen door open in 3 intervals, as it were, proving that you open the door and that it closed, and then 2 weeks later do the same. Open the door and prove that it closed, and then over 5, and do that 3 times, and then over 5 years, follow folks to see what occurs with their disease process. Do they maintain cognitive function, and how long can they, can we follow folks as long as possible? Now, the purpose of the technology, if you ask me, I think is fascinating because it entirely changes the mindset with which the healthcare world is really approaching Alzheimer's disease itself. Instead of trying to symptom control, support, recognize that the yellow line's not moving anywhere, but maybe make the course of that yellow line less unpleasant, can we actually alter the line itself? Can we change the direction that it's going? And to many extent, the vision is that by opening the blood-brain barrier, that opens the door in ways that approach unique. It's a unique approach to disease therapy that has never really been there before. The brain is a troublesome organ because once you're on the inside, there's really no way to get in. Can you open that barrier? But it's not just about letting the dogs out. Could we open the door and let stuff in that we couldn't let in before and the brain has managed to keep out? By figuring out how to open this door safely, the initial study, while focused in this very specific question, it really is the first step toward changing the way that we think about how the brain protects itself, how diseases occur, and can we intervene with disease processes before they become life-altering in some way. And so in some sense, I think the study itself, while is unique in one vision, in one aspect of the disease, the healthcare world has really not forgotten that this is a problem that is only going to continue to become more and more prevalent, become more and more relevant, become more and more difficult societally, economically, financially, emotionally. It's becoming more and more relevant. So to some extent, the healthcare world is really focused. We're proud to be part of this because being forward-thinking means don't let's just fix the problem. How do we fix the problem for the future so that we don't even have the problem to begin with? And to that end, I think this is, again, another vision of how do we make things better. And so, again, I thank everybody for allowing me that one window into what it is that the healthcare world is thinking about when it comes to Alzheimer's disease. Thank you.
Good morning. How is everyone today? Good. I'm so happy to see all of you come together. This morning when I was actually in the lobby, and it was interesting to hear all those conversations, people were actually talking about, I'm having vision problems, I'm having hearing problems. And then there was one table which was actually talking about sleep and incontinence. And I was like, wow, after such a long time, people are actually coming together and talking. And it was so interesting to see this. And I really thank ADRC to actually invite me to meet with you guys. It's a great opportunity. So now everyone is awake, I'm sure, right? Okay, so now I can talk about sleep. And I hope that you do take some pearls from here, and if you do not, just listen to my presentation tonight, and hopefully it's so boring that you can get some sleep. Okay, so now quickly, because I know time is short, I'm going to go through my slides and talk about this. Okay, so I'm Shweta Tiwari, and I work with the Department of Geriatrics, Nova Southeastern University. I'm an assistant professor. I'm also an administrator director of the Geriatric Workforce Enhancement Program. Dr. Pandya, who just spoke in the beginning, she's the principal investigator of the program. And this presentation is funded by our nationally recognized federal body, which is HRSA. I have no conflicts. Okay, so I'm sorry, I moved ahead. So the three objectives of my presentation are, we'll talk about how sleep works. We'll also learn how to improve our sleep. And there's a small caregivers sleep study which we did like several years back, and there were some important takeaway points. So I'll quickly go through those as well. Uh-oh. Okay, fun question. And if no one has seen the answer, how many times do you think our body is programmed to sleep? Once, twice, 3 times, 4 times? 3? 5? Good choice. 6? Oh my God, we sleep so much. Okay. 8? Wow, okay. So let's see what experts have found out. 2 times. There are 2 periods our body is actually programmed to sleep. One is the primary between midnight to 7 p.m. in the morning, and the second is the time when we usually nap, like 1 to 4 in the afternoon. Stages of sleep cycle. And I thought this is a little bit of clinical information, but it's important because it helps us to understand how we sleep. So when I was looking at the literature, I found that there are 5 different periods that the experts felt that that we go through the entire night. But over a period of time, they consolidated into 4 periods. Well, a little less for us to remember, but I guess it's easier. The 2 main one is the 2 important ones are the rapid eye movement sleep and the non-REM sleep. Now, non-REM sleep or the non-rapid eye movement sleep is divided into 3 categories, which is N1, N2, and N3. N1 category is basically when we are going into that primary period of sleep between wakefulness to the early sleeping time. So that's the first cycle. And you will see that your muscles are going to relax, your eye movements are going to be slower, and you're kind of getting into a light sleep mode. N2 sleep is basically the sleep where we are the longest period of time. I'm looking at 30 to 60 minutes. Our muscles are relaxed, or breathing is much slower, and our eye movements are also reduced. And the N3 sleep, which is where we feel we all need that N3 sleep so that we feel relaxed, and that lasts between 20 to 40 minutes. It's a deep sleep, and again our body has some movements but not a lot. Now, the rapid eye movement sleep, and it's important to know about the rapid eye movement sleep because it starts after, I think, the first 90 minutes of N1, N2, and N3 sleep. This is where most of the dreaming happens. And it's very difficult for us to be awakened. In fact, our body becomes like a little paralyzed. So that is rapid eye movement sleep. Also, I want to tell you that memory consolidation actually happens with both REM sleep and non-REM sleep. And why is it important for us to know? Because as we age, the REM sleep becomes less. So if you're looking at the slide, during the infancy stage, you'll see the REM period is the longest. And if you look at the old age, the REM period is actually reducing. Changes in sleep with aging. Yes, we cannot enjoy the same sleep which we enjoyed when we were adolescents, 10 hours of sleep. So as we age, our sleep architecture definitely changes. As you heard from Dr. Pandya and Dr. Meskowitz, they talked about disruptions in sleep, like any medical psychiatric disorders, they further add on to the sleep burden. So yes, there are sleep issues as we age. And basically, if you looked at the non-REM and the REM sleeps, these are the different factors which kind of impact our sleep changes. So if you're looking at the sleep characteristic, our total sleep time decreases as we age. Sleep latency, it can increase or there could be no change. Daytime napping, it increases as we have all seen. We tend to nap more as we grow older. Stages N1 and N2, they increase. As we talked about, the REM sleep decreases. Then we have the slow wave sleep stage, N3, that also decreases. And rapid eye movement, we talked about, that decreases as well. So what can we do? I mean, we know that as we age, we sleep less. There are disruptions in sleep due to Alzheimer's and dementia. There's so many different treatments which are available. We have clinical interventions, we have non-clinical interventions. With multiple medications which we take, we tend to move to the non-pharmacological interventions as much as we possible in order to reduce side effects. So I was looking in the literature to see what exactly is there which has worked for people with dementia or people without dementia. And I found that cognitive behavior therapy is one of the most cited intervention that has helped with sleep disorders. What exactly CBT? Anyone there? Cognitive behavior therapy, anyone knows what it is? So different terminologies. Some people call it talking therapy, some people call it psychotherapy. I also heard a different term called goal setting, like you set goals for your you set your goals for what you want to do. But basically cognitive behavior therapy it tells you that the way we think, the way we feel, and the way we act, those are the things that the therapists are actually working at in order to improve the way we sleep. So that's what cognitive behavior therapy is. So there's two studies which I have cited here. The first one, if you look at the left, is a randomized clinical trial with 303 patients with chronic insomnia, and 151 actually included medical and psychiatric comorbidities. The intervention was internet-based CBT, so important during this pandemic time when you cannot actually not visit your therapist. It was internet-based CBT, and what they found was there was a decrease in insomnia severity index. So that was one good thing. The second study which I looked at was more of a review study, which is like, kind of looking at each and every article, which looked at CBT and kind of summarizing whether CBT really worked or not. And in that situation, if we look, there was a decrease in insomnia by 4.4%, and depression by 2.3%. 2.3 points, I'm sorry. So that was, again, a meta-analysis. So we talked about cognitive behavior therapy, and very quickly I want to tell you what it really entails. They talk about sleep stimulus control, and stimulus control is basically, I'm sure a lot of you have heard about it, but no TV, no cell phone when you're sleeping. Patient is asked to reduce nap time. We're supposed to have consistent sleeping time and rising time. So the therapist is working with the patient to see that we are kind of consistent in that modality. Then we have sleep restriction. Sleep restriction refers to, for example, if we go to bed, for example, at 8 o'clock in the night, and we're getting up at 6 o'clock in the morning. But actually, we are sleeping only from 10 to 6. So we are wasting our time in bed. So what sleep experts are working with you is to see that you spend maximum time sleeping in bed, which is a sleep efficiency. So they're trying to improve your sleep efficiency. So that's what sleep restriction works on. And I don't know how many of you go through this, but I have done this. Like if I'm on my cell phone or something in the night, that's what I do. 3 hours just lying down there and sleeping at 12 o'clock midnight. Bright light, this is another important category, and I'm going to talk a little bit about this, but in cognitive behavior therapy, they talk about bright light because it also improves your circadian rhythm, which is very important for you to get better sleep. Again, I know you need your eye test before and after just to see if it's kind of impacting your sight or not. So in summary, if you look at it, cognitive behavior therapy, the way it works, it kind of uses one or the other approach to see what works with the patient. They also use relaxation techniques like meditation, just kind of helping you de-stress or changing any maladaptive information which you have about sleep. So they'll talk you through that so that you can get better sleep at night. Another review study, I know I'm not going to talk a lot about the literature, but just to kind of reinforce that physical stimulation and sensory stimulation do help in getting better sleep. I skipped through this, which is the most important thing, exercise. Exercise for a person of dementia is really important. It's important for anyone, but anyone with dementia who is struggling to sleep, exercise is something which can be really helpful. And I mean, we all know we need to exercise like 30 minutes a day. 30 minutes a day can be very stressful for someone with dementia. So they suggest like break it out, like, 10 minutes in the morning, 10 minutes in the afternoon, 10 minutes in the evening. What it does to your body is it stimulates you and helps you sleep better. But remember, do not exercise late in the night because it's going to alert you, and that's what's going to make it difficult for a person of dementia to sleep. So the loved ones need to remember that this is something which they have to consider. Yes, it is difficult to establish a routine, so you have to work with your loved ones to see whether you can establish a routine for exercise or not. You can go for a walk. You can do some fun stuff like dancing, ballroom dancing. Sometimes, persons with dementia really enjoy that. Or ask what they can do in order to improve, or, do you have an exercise buddy in your community you can exercise with? So kind of be creative around, how to kind of exercise. You don't have to be on a treadmill to exercise. I also want to talk about the safety characteristics or safety features you need to remember while you're exercising. See if your loved one is wearing proper shoe. Look at the weather, what kind of weather it is. It's raining, it's snowing, whatever, and then tailor your exercise based on that. Once I remember I was in a facility and I saw a woman sitting in a wheelchair and just, gently waving her arms. And even those gentle exercises can help you a lot or stimulate you enough to fall asleep. Bright light. Remember we spoke about bright light when we were talking about cognitive behavior therapy? Yes, it's very important. Experts suggest that 30 to 60 minutes of bright light can really help you sleep better. But again, bright light doesn't mean you go outside, in broad daylight in the sun and kind of, get sunburns. No. Because they say the kind of light which is required to help you sleep better, it actually comes through the clouds. So you can be sitting next to the porch or, just kind of step out maybe late evening, and that can also help you sleep better. Check with your insurance company. There's some light boxes which might help you sleep better as well, and see if you can buy those and keep it next to your chair. Sleep diary. Another thing which, while working with your loved ones or caregivers, experts work with is keeping a sleep diary. What time did you sleep? 8 o'clock. What time did you wake up? 4 o'clock. Is that changing every day? If it's changing, what are the reasons? Are you going to the bathroom quite often? What's really triggering those awakenings? And it's important to know that on a daily basis, we tend to forget these things. So sleep diary is another thing which you should keep if you're having trouble sleeping. Sleep hygiene, very important. There's several sleep hygiene suggestions floating all around. So do what works best for you. If a glass of milk works best for you, take it. If a banana works best for you, do that, so whatever. For me, I know what works best for me. I have to keep my cell phone away. It's a habit which I have to develop, and I know it's hard, but that's a very important element for sleep hygiene. So this is something which I do want to talk about, and I know this is an old study, but it's very dear to me because I personally worked on it. We developed a sleep manual. We recruited 7 caregivers who had loved ones with dementia. It was a 6-week study, and what we did is we researched a lot of strategies that have worked with caregivers who are working with dementia to see if it works with them or not. And every week we'll provide those strategies to these caregivers who will come together in a group setting, and they'll discuss about it. They'll go home and practice those strategies with their loved ones, and the next week they'll come and discuss their issues. So the study ran for 6 weeks. We had several instruments which we, administered at point of time. Trust me, that probably was one of the best times that I had, because it was such close conversation with these people and what they go through that you actually feel that doing some good work at that point of time when you're helping these people. And what I found out was that we had like 6 to 7 caregivers, as I said, they had depression scores. This is pre-test I'm talking about. So depression was really high. But after the 6 week, we found that 3 of the subjects had reduced depression. 5 of 7 participants scored moderate to severe with regards to burden. And when I say burden, it's caregiver burden, which we pre-tested and post-tested. Not a lot of difference, and I can understand that because, sleep is not the only issue that the caregiver is dealing with. There's several other issues. So caregiver burden actually is associated with many things. So we didn't find a lot of difference there. But sleep problems, which was a big one, was very high before the study. And we found that there was a big improvement in that category. But again, this was a pilot study. It's just 7 people, so I really cannot say much. But I think what also worked, when the caregivers came together and they spoke to each other and they found what each one of them is using to help them reduce, stress or even kind of help sleep better, that probably was also an element. So we talked a lot about that in one of my sleep chapters and one of my papers. And people appreciated that. And I have a sleep manual, so if anyone actually wants to look at it, I can definitely provide the sleep manual as well. Okay, so I'm going to end here, but very quickly I want to show you this. Please, this is an evaluation survey which I would like you to complete. It's something which we report to HRSA, and also some feedback about this presentation so that I can improve this talk again if I'm going to present again. Thank you so much.
Good morning. Let's give our panelists a warm round of applause. My presentation was supposed to be for 15 minutes, but as always, when I'm on a panel with researchers, they cut my time. But it is so refreshing to hear this information because it definitely matters. Research definitely matters. My name is Keith Gibson, and I'm a caregiver. My story started when my brother, who died at age 54, suffered 2 major medical events at the same time. And to get the diagnosis for vascular dementia, it was a bit of a challenge for me. And so I know that I don't have the time to really go deep into my story, but to me, my work is personal as well as professional. So that's my personal connection to the disease. My professional connection to the disease is that I am the State Director for Diversity, Equity, and Inclusion for the Alzheimer's Association, and I'm one of 3 research champions for the Alzheimer's Association. And that last title, it's super exciting for me because if you want to say to me, well, what does a research champion do? Basically, I am a big fan of researchers. We are very fortunate here in Southeast Florida to be at the hotbed of some of the greatest researchers that are providing the greatest opportunity for us to make a difference regarding this terrible, terrible disease. So I just want to say, again, give it up for our researchers here because their work does matter. Because research does matter. So real quickly, I'm going to do a 3-minute drill here. Okay. All right. So behind research, there are efforts that fuel what the Alzheimer's Association does because something is always happening. So this presentation is really about at any given moment. I want you to pay attention to that theme. At any given moment, research is happening. And I challenge you to become educated because if you're a caregiver, to define whether or not you're a good or bad caregiver, it depends on how you look at yourself. You are going to become a student of this disease whether you choose to or not. It's up to you in terms of what type of student that you will become. And the best students are the ones that can manage their emotions and also to help manage their loved one's care. So you have to be able to really invest in being a caregiver, okay? Because I'm here to tell you, I'm the hype man. With research, there's hope. There's hope. So you want to learn as much as you possibly can. Okay. So at any given moment, something is happening in research. The Alzheimer's Association is the world's largest nonprofit funder of research behind two governments. One is the United States and the other one is China. Okay? Right now, there's over $310 million invested in more than 950 projects in 48 countries. That's a lot. That's a lot. And I was very fortunate to be able to attend our conference in San Diego, where we had researchers there from over 98 countries talking about their research. And listen, I'm not a researcher, so I don't have that research mind, because whenever I hear these researchers talk, a lot of that stuff goes over my head. But then I go to them, I said, okay, could you break that down so I can understand what your research is all about? And they're very gracious enough to do that. When we talk about the impact of this disease, this is very, very important. About 2/3 of Americans that have this disease are women. Yep. And another statistic that you need to be aware of, that older blacks are 2 times likely to have this disease than older white Americans. Hispanics are 1.5 times likely to have this disease than older white Americans. That's important because here's the question. Why is diversity important in research? Because the biology of everyone is different. I did an interview about 4 months ago, and the reporter asked me this question. So why is diversity so important in clinical trials and research? Because the biology is different from the black community, the Hispanic community, and the white community. So all communities need to be involved in research. Bottom line. Okay. At any given moment, research is happening. What we're talking about is that we at the Alzheimer's Association, we power translational research by what we call a program called Part the Cloud. The Part the Cloud research, which we fund, is that innovative, cutting edge that normally the NIH will not fund. But we know that in order for us to really find a way to slow this disease down, we have to think outside the box. Because what's going to happen is it's not going to be just one type of medication that's going to be it. It's going to take a combination of different things. The Alzheimer's Association, as I pointed it out earlier, we're the world's largest nonprofit funder of Alzheimer's research. We are working to make sure that we fund the best projects no matter where they're taking place, no matter where in the world, okay? And we are encouraging what we need to recruit early investigators, meaning new people to come in and to get involved in research, because it's super, super important. Okay, again, at any given moment, and I hope that you've been paying attention to the cities and the time to illustrate the point, that any given moment, learning is happening. We connect across industries and we share information. That's one of the things when we convene our researchers every year at our International Research Conference, that we get them to talk about their research and they share the information with each other. So we don't work in silos, because it's important that if one research fails, that information and that data could be helpful to another researcher in their research. So all research matters. And that's just what I got finished talking about, our International Research Conference. I was there in San Diego, and it was an amazing conference. There was over 5,000 people there in person and another 5,000 online. Next year, it's going to be in Amsterdam. I plan on being there because, I'm going. Because I need to come back and report out about this amazing research that's going on. Okay, so we at the Alzheimer's Association, we have the most powerful peer-reviewed journal in dementia science. It's known as the Alzheimer's and Dementia, the Journal of the Alzheimer's Association. It's well worth it because you need to know about what's going on. You're probably saying, well, I'm a caregiver. I'm right in the middle of this battle right now. So why should I be concerned or be interested in learning about research? I'll tell you why. Because you have a story to tell, okay? And yes, your loved one may not be able to experience that breakthrough when it comes to research, but to say that, you know what, you're keeping their legacy alive. Because I tell folks this all the time, I have the greatest job in the world because I get to keep my brother's legacy alive. Because I talk to other caregivers and give them that hope to share my story, and you have a responsibility to your loved one to share your story, because that's going to help the next caregiver that's coming on board that doesn't have a clue about what to expect, but you can share your experience to give them that hope. And again, our groundbreaking actions that establish foundations that make today's advances possible. So, again, the Alzheimer's Association plays a very vital role in everything that we do, in everything that's all research. And we advocate for studies, okay, and that propel the field forward, because we know that we have to be fully invested in finding that way to slow this disease down. And as was pointed out earlier, with these new studies and these new advances, there's going to be controversy. Is it going to be perfect? No, it's not. But I'm going to tell you this. We have to change the culture of our government, okay? We have to change the culture of our government, because they need to understand that in order for us, because whenever we find a new method to slow this, or a treatment to slow this disease down, it's going to cost money. But it has to be affordable for all people. And our government has a responsibility to help pay for that. And the last thing I want to share with you is that you have an opportunity to stay informed. You can do this through an app called the Science Hub. This is where you can have your finger on the latest research that's coming down the pike. And you can actually, everybody take out your cell phone right now, if you have one, and go to your, if you have Android, go to the Google Play Store, and you can download the Science Hub app. That's how you're going to get the latest information that is going on in research today. It is at your fingertips. To me, I have it on my phone. Oh, did you get that? All righty. I know I ran over, but it was my privilege and pleasure to be able to share with you this information. And again, give it up for my fellow panelists. Their information is amazing. I'm sitting here listening to Dr. Swati, and I said, you know what? I'm going to have to do a program with her, because one of the topics that was discussed at our International Research Conference was, believe it or not, on sleep. Sleep is important. So again, give it up for everyone that's on this panel. Thank you.
Thanks, Vicky. Very good.